How's everyone doing this Thursday afternoon? One good. Okay. Are you guys feeling the first week? Are you feeling a little bit overwhelmed after some of you have been off for the summer? Some of you guys have been off for longer than the summer. So welcome to HSMD 5500. This room is really hot, and I apologize, but just think how hot you feel. I'm gonna be right in this corner, and like it's even warmer behind all this stuff, so I understand how hot you are. So if I start sweating, don't worry, I'm fine. Let's see, so today we have a lot going on. We'll do a little bit of a review of the D2L, but there is 2 videos since my microphone failed about 5 minutes towards the end of the first video on the D2L site. Has anyone had any trouble getting on D2L? Now, if you get onto D2L and you don't see a lot, that's because you haven't either taken the syllabus quiz or haven't passed it. And I saw a couple of people had taken it, but they hadn't gotten 100%. So if you only see a couple little things, like the course outline, syllabus, and the assignments, and I think final review is on there as well, but none of the modules, that's a good indication that you've either not taken the syllabus quiz or you didn't pass it with 100%. It's not a hard quiz, and you can find it when you click on syllabus. Any questions about how that works? I had a student last year who, because you can see the assignments, he was doing stuff, but he was like, I don't know, why don't you post the PowerPoints? And why don't you do this? What are you talking about? He had not taken the syllabus quiz for like 6 weeks. So let's not be that student, okay guys? Because then I was really like, how are you doing this class? So make sure you do that. How many of you have taken or have a background in public health? Undergraduate public health. Okay. So for a lot of you, this semester is going to be a lot of new content, not only in this class, but others. So just like strap in and be ready, okay? Before we do that, I guess I should introduce myself and your teaching assistant. I'll let him introduce himself as well. We both did little intro videos, but if you haven't had a chance to watch it, I'm Dr. Kate Beatty. I'm an assistant professor in the College of Public Health. I'm in Health Services Management and Policy. So if you want to find me, my door is always open, but you have to find me because I'm on G1? Yeah. G1. So where CM Wilson is, there's a parking lot. If you come in through that side of the building, you can find health admin pretty easily. If not, there's not this elevator, but another elevator. And if you go down to G1, you can find me. Or there's staircases. So my door's always open, you just have to find me. And and you can make meeting requests with me. You can stop by. Priscilla Wisdom is our executive aide, and she usually can help navigate you if you just pop in to see if I'm there. This is the beginning of my 5th year here at ETSU, and it's the 5th time I'm teaching this course. This is the last time I'm teaching this course because we're going through a revision of our curriculum, and this course and with this name and in this setup will no longer exist. So I'm kind of sad. I love this course, but don't worry. The content will be for future MPHers. They'll be able to get all this content. It's just going to be intermingled into different courses. Let's see. So I have a master's in public health with a dual concentration in epidemiology and behavioral health. I really like statistics and biostatistics. I try not to geek out too much in this class because I don't want you guys to, get lost or think I'm not cool. But I also have my PhD in public health studies. I got all my public health degrees at St. Louis University in St. Louis, Missouri. My research focuses on public health systems. So we have a model, a framework that I'm going to share with you that kind of is the bedrock of how we think about public health systems. And systems thinking is a little bit challenging at first when you're learning new information, but it's really important for you guys to kind of understand that public health is made up of a bunch of different moving parts. Different organizations are part of public health, not just governmental. But we have inputs and outputs and all this stuff. So that's where my research is focused, has been on public health systems. I do research on evaluation and organizational evaluations, and also content areas are childhood obesity and women's contraceptive health. So if anything that I said sounds interesting to you and you want to talk about it, I love talking about that part. I don't get to bring too much of my research into this course because it's really kind of like a survey of all these different parts of public health admin. You'll see these content areas, and if you're going to be in our concentration, often these content areas are whole courses. So we're really just going to be touching the surface of a lot of interesting topics around public health and healthcare administration, because this course covers both. When I'm not here, I spend a lot of time with my family. I'm married and I have 2 kids. I have a 2-year-old and now a almost 3-month-old. So I'm reading all your cool things you did this summer, and I spent most of my summer hanging out with an infant, which was really fun in my opinion. But so that's a little bit about me. I have 2 dogs. I live in the Tree Streets. I like to eat food, and my husband used to be a brewer at Johnson City Brewing Company, so he knows a lot about beer. So just come talk to me about any of that stuff. I think that beer. I don't know much about beer, but he does. He might bore you a little bit. I think that's it about me, and I'll let Sylvester give his intro.
Oh yeah, so I'm Sylvester. I'm also an MPH student like you guys. Although this is gonna be my final semester, so yeah, don't be jealous. Yeah. So I'm in the biostatistics concentration. At the same time, my background is in information technology or computer science. So I have a PhD in IT, focusing on machine learning and artificial intelligence. I'm also working on Alzheimer's disease. I develop predictive algorithms to detect early onset Alzheimer's disease from speech. So if you think you are interested in that area, I'll be glad, to discuss with you. So I'll be available to help you guys in any way I can. I took this course once. I also mentioned that in the video. I enjoyed it. She's an amazing lecturer. You will love it. You don't want to go through your MPH without, being taught by Dr. Ben. So that's just the truth, okay?
I'm his boss now, so that's why he's saying all this.
All right, yeah. So, yeah, I'll be available to respond to you guys via emails. And if you want to have a one-on-one meeting with me, my office is at room 41. It's just right opposite our office. So once you get to G1, it's not difficult to find.
Once you get down to G1.
Or you can look for Priscilla. Priscilla knows where. Even if we are hiding, she's gonna find it. Yeah. So I'm glad you guys are here, and welcome to ETSU.
Thank you. All right, any questions for us? All right, we'll do a little icebreaker in the middle of the class. Just when you're about to start to fall asleep, we'll get you guys moving again. So as I mentioned, this course is kind of like a survey course of all kinds of information. Let's go to the syllabus because that's where I actually have the course out. There's a lot in course content that is interactive, but I'm just going to go to the course outline. So because this course covers content across public health and health care administration, we have what you would think is guest lectures from different folks from within our department. And over the years, Dr. Corey, who's the chair of our department, and I used to co-teach this course. And so when she handed it over just to me, there's 3 lectures that she just couldn't let go of. She really loves talking about these. So she's gonna be here with you guys weeks 4 through 6, so right up until the midterm examination, talking about strategic planning, and then we have 2 weeks to go over program planning, management, and evaluation. She is someone that is the PI for this huge grant that I'm a part of that's looking at the impact of a statewide initiative on women's access to contraceptives and contraceptive care. So she is very knowledgeable about program planning and management and evaluation. So that will be a good, those 3 weeks will be really great. Week 3, Amy Weber, who's one of our doctoral students in the department, will be talking to you guys about leadership and partnerships. I typically do that lecture, but I'll be at TPHA that day. So she's gonna come and step in. She's been a teaching assistant for this class, and she's also been an instructor for other classes, and that's a good lecture. And then we have Dr. Hale, who is gonna be talking to you about the organization, financing, and delivery of healthcare services and healthcare reform. Last year was the first time I had him come in and talk about these, and the evaluation students just loved these lectures from him. I think you guys will enjoy it too. He has a very rich knowledge of this, and then he also will tell it to you straight. So he'll tell you what the book says, and then he'll tell you his opinion, and then he'll let you guys think through what your opinions are about these things. Healthcare reform is the one lecture that in 5 years I've never been able to not almost scrap and have to redo, because we're living in a very dynamic time around healthcare and healthcare reform. So I think of it as an amazing time for you guys to be learning about this as well. Some people can see that as a plus or minus. There's a lot of changes that are going on. There could be changes happening this semester that we don't even know about, because we're getting close to the elections in November, and sometimes things happen right around elections to try to get people to vote certain ways. So I cannot predict what will be happening in healthcare reform, but I think that's kind of the fun part about doing this work. And then at the very end, Dr. Smith, who is another faculty in our department, he is teaching with Sylvester this semester the undergraduate information technology.
Health informatics.
Health informatics course. He's spent over a decade in public health practice. He is a math major, and he has his master's in biostatistics and his doctorate in biostatistics. But he's able to really make the connection between how we need all this great data, right, in public health. But if the data just sits in a place where only we can talk about it, it doesn't really do much for the greater population. So he does a really good lecture on that. So that's kind of a quick snapshot into all the people who will be in the classroom over the semester. But we are your point people, and I will be the one who manages the course, and Sylvester will be my right-hand man in that. So one thing, if you have questions, it's really better for you to send an email to both of us, CC both of us on it. I work mostly during the day and early mornings. Sylvester, I don't know your working style. Are you
Most of the day through late evening.
Okay, so you're a night owl and I'm a rooster. So, depending on if the night owl is up while the rooster's asleep, then Sylvester might be able to answer a question, or I can get to it. So that helps us be more efficient. Don't send us both the email and not CC, because then we're just gonna duplicate work. But if you send it to both of us, that'll ensure that we can get to your questions as quickly as possible. Email is the best way to contact either of us. All right, any questions about the syllabus right now or the course? Okay, I know I'm your last professor of the week, but we can't just have silence the whole time. It's gonna be really hard for me. All right, so we'll go ahead and start talking about our content today. So this week we're gonna go and just do an overview of public health systems. We've got a couple different sections throughout this lecture that we're gonna break it up into. And then we'll take a break and we'll do some icebreakers. So there's a little bit of interactivity as well. So at the beginning of any of my lecture slides, you'll see a list of learning objectives. I will not read them to you because I know you can read, but this is just helping you see and make the links between the content covered in the lecture and the overall goals of the course. So we're going to start with just this broad understanding of what is public health, including the mission, what we call the core functions and essential services that will really kind of give you a foundation of what we're going to be talking about this semester. Okay, so we're going to do an activity, and these are headlines. And so each one, I want you to read it, we'll read it, and you tell me if this one is related to public health or not. Puppet Man Jim Henson dies dead at 53. No. Why is this not public health? It's just about one individual. Now, if he died of tuberculosis or something, or like a strain of tuberculosis that's infecting the population, maybe. But right now, we're just looking at the death of one individual. Okay, longevity gap among races. Whites live 6 years longer than blacks. Yes. And why?
Because you're looking at a population count.
Yeah, so we're looking at populations and segments of a population. Legislator to ban smoking in facilities.
Yes.
Yes. So this one relates to a public health policy initiative. For companies, falling isn't free.
Yes.
Yes? Is that a resounding yes? What does this have to do with?
Occupational safety.
Occupational? Yeah. So this has to do with occupational health, which falls under public health. Countries lag in treating mental health, WHO says.
Yes.
Treatment of pneumonia improved at state hospitals.
Yes.
Yeah, so this is a specific part of the population, right? Those that are within the state's hospitals, and the hospitals are part of the larger health and public health system. And then contaminated food sickens millions.
Yes.
And finally, starved child's health improves. No, right? Again, just like the Jim Henson one, it's about one child. Though these are important things, they're just not public health. So the mission of public health is to promote the physical and mental health, promote physical and mental health and prevent disease, injury, and disability. So it's fulfilling society's interest in ensuring conditions in which people can be healthy. And that was from a seminal report from the Institute of Medicine in 1988, which really helped define what public health is. Okay, so we're gonna watch a little video, and I should have tried this ahead of time. pause that and make sure we have our sound on. Okay. Let's make this large screen. Go back. How does that make you guys feel? Yes. That always gets me choked up. So that is a great video. So if you're family members, so when I started in public health many years ago, and I told my family, getting my master's in public health, they're like, that's great. What is that? Like, they just didn't get it. Show them this video and they'll be pumped for you as well. Okay, so a lot of us in public health know and can understand the difference between public health and medicine. Some of the lines are blurring more so, and I think that's a good thing because we have more of a connection with medicine now. But really, when we think of public health, and many of the students that come into public health, when they're in their undergrads and they may think they want to go somewhere clinical, they start to think about it and think, you know, I would love to be in a field where it's not treating or preventing illness. And so that's really what public health is. It's an emphasis on prevention. We'll talk about it a little bit later in the semester, but that the return on investment is there. If we prevent a disease from happening, that's going to save us money. But preventing disease also prevents disability, poor health, etc. So we want to focus on that. And then as you guys illustrated in that, in those examples, it's a focus on community, not on the individual. So we're thinking of the health of communities. And those communities are made up of people, and it's important that their health is good, but we're really focusing on how we can go what we often call upstream. So programs and things that address multiple social and environment determinants of health. So going beyond just what the individual has in themselves genetically or their behaviors, but what are the things set up in society or in the environment that impact health. Because again, if we can impact at that level, we're gonna get more bang for our buck. We're gonna make a bigger difference. And so clinical medicine focuses more on the treatment of the individual. So it's a different unit of analysis, a unit of focus. Okay, so here's that framework I mentioned to you. So we're gonna spend a couple minutes on this. And this is what we call the framework of the public health system. So we will start at the environment. As I just mentioned, the environment impacts health, right? So the environment is what we think of as a social, political, public policy, economic, cultural, demographic, technological context, which we all reside. And the public health system is below that. So if we think about communities, they differ. So coming from St. Louis, Missouri to Johnson City, Tennessee was slightly a culture shock, right? They're different, not in a bad way. One is an urban core with a diverse population culturally and ethnically and racially. And it's big, there's a lot of people. Johnson City is smaller. The population is less ethnically and racially diverse. But there's a lot of similarities in the issues that affect those communities. Individuals with low income in both those communities are disadvantaged, right? But they're different. And so the public health system has to be aware of the context they're in. Because if we're going to make a difference in the community, it's not a one size fits all. What works in St. Louis doesn't necessarily work in Johnson City. What works in Tennessee may not work in New Jersey. It may, but we can't assume it does. So we always have to think about how the public health system fits within the environment. So within the public health systems, we have what we think of as inputs, processes, and outputs. The structure is what us organizational behavioral researchers can think of as those things that make up the organization. So it's the workforce, the finances, it's how it's governed, how its leadership is made up of, their information systems. And this structure impacts what the system can do. So if you're, for example, the administrator of a health department in a small community, you may only have 5 employees and a very small budget because your budget's based on your population that you serve. So you serve a smaller population, the state gives you a smaller budget. That seems fair, right? Smaller budget for smaller population. But 5 people can only do so much stuff. So the size of your workforce is going to impact what they actually can do in the community. And that process, which we'll talk about in a second, is the essential public health services. So those are going to be all the things that, when you think about what public health does, if those are the services that are traditionally within the prevention side of public health. There are also processes that happen that are outside of the essential public health services, but just for this illustration, we'll focus in on that. And so your structure impacts that process. And that process provision of services to your community leads to a certain outcome. And we want to make sure that it's effective, efficient, and equitable. But so we're in this cycle, and again, the environment will impact how much we can make a difference on the outcome. So communities that have poorer health outcomes, if you were to take a step back and look at some of the determinants, you'd see a lot of it's in this cultural level, this environmental level. So again, we are working within this larger framework of public health. Does this make sense? Okay. We'll come back to this next week and we'll do a little activity, and then you'll realize how much it does and doesn't make sense, which is okay. Because systems thinking, like I said, is something that we hope you obtain by the time you finish your program here. But just giving you a primer into how the systems thinking works. And a lot more, as I mentioned, public health and healthcare are kind of no longer as far apart. And you'll hear this word population health, and we actually have a whole course on population health that's taught by Dr. Hale. Because we're moving from just the focus on traditional public health. So the public health that happens in local and state health departments, to thinking of population health as including the healthcare system and how it interacts with public health, as well as social policies that may impact the health of communities. So we're kind of taking and blowing up our original idea of public health, because we know the stuff that we do in public health is not done in a vacuum. It's impacted and can be improved on by working with partners, and working around policy development. So here I have like two pictures in my lecture that are just two different ways to kind of visualize. This one has like the names of different groups, and the other one is more of a social network kind of thing. So to assure the conditions for population health, so for improvement of communities' health, governmental public health is only one aspect. And it's not only governmental health and healthcare delivery system. So let's think about those you can tangibly think about. You know, if you don't have access to healthcare, then you're not going to meet those individual needs of community members. So if they're sick, they don't have a place to go. So we can tangibly think about that, or that makes logical sense. But what role do businesses and employers have on health?
They can provide insurance.
They can provide insurance, so they can provide access to healthcare. What else can they do?
They should be ensuring that safety standards are being met in compliance with OSHA.
Yeah, so from that environmental health, occupational health perspective, if you have employers who are not providing safe work environments for their employees, that's going to impact them. Conversely, if they have a great place to work that's safe, that's going to improve the health of the community. What else can they do? What else can they do?
The amount of if their wages are like equitable or not can influence the quality of like life that the person is able to live.
Yeah, so employers and businesses help with the economic drivers in communities. So communities that have a robust economic outlook, so there's lots of companies, lots of businesses, places where people from different strata in society can work, you're going to find a healthier community than one that has lost jobs, lost employers, and you have a lot of people without jobs. So that's really kind of, they provide insurance and on-the-job safety, but really they can help improve the population health, because if we have jobs that can help people not only pay for insurance or get access to insurance, what are other things that money can buy? Happiness? No, just kidding. What can the money buy? Food, lodging,
Security.
security, yeah. How does the media, how can the media play a role?
Well, you can have the positive effect of spreading important news and information, or you can have the negative effect of like fear mongering.
Yeah, so we can use, and we have a health communications course that's taught in community health that I'm sure goes a lot into how you can use the media to communicate messages. It's a great way. If you have a message you want to get out, those media and communications experts, they're great at creating sharp pieces of content that can spread messages to a whole community. What are some media, does anything come to mind? Our students? Yeah.
I think it's two things. I think they're kind of preventative because I know over summer they will talk about applying your sunscreen
Mm-hmm.
or that's the name of that honestly thing of during the summer that comes to mind.
Sunscreen, what are you gonna start hearing soon?
Flu shots.
Flu shots, get your flu shots. Yeah, so you can use the media for that, and you were thinking of something else, you said?
I can't think of the other one.
Okay.
Yes.
Yeah, and then think of the Truth campaign, is everybody too young for that, or is that still a thing?
Oh, for non-smoking.
For smoking. So, the Truth campaign came out, and it used money from settlements from tobacco companies to create a really great media campaign that was called the Truth Campaign, telling you what tobacco companies are doing to get you hooked on their cigarettes. So that's one way for media. What about the community? How does the community assure conditions for population health?
Support programs.
Support for
I mean, like, I don't know, just support for anything.
support, like so community organizations that are civic or somehow may help support public health. That's a good one.
Yeah, like health centers that might like focus on like, or maybe an alternate provider for like contraceptives and
Health centers. Yeah, so when we think of the community, this could be community organizations, these could be leaders. Sometimes it just takes one person who's just really passionate to help move things, move change. Maybe they just start one 5K or some program after school and it grows and grows and grows. But those are the community involvement. If we in public health just sat around this room and tried to solve the problems for our communities, we would not make very much progress because we need the input and the buy-in of our communities. So when you are working on your team projects, the first part is a coalition project, and Amy's going to come in and talk a lot more about community partners and leadership. But when you're thinking about that, you want to make sure that if you're trying to address a problem in a community, you'd be very remiss not to include the community in that effort. Okay, so here is a kind of social network map that shows you just the interactions between different types of players in the public health system. So you have the agency in the middle, but then there are all these different types of organizations and groups that interact to ensure that public health can do its job. And this includes faith institutions, so that's part of the community, civics groups. We've got community centers, as you mentioned, transit. This is key. When we talk about some of the major barriers in communities, especially in this region, it's transportation. For older individuals in communities, it's transportation. So public health and transit should be working together. Any questions on the public health systems piece? Does this make sense? Okay. So, when you think of the processes and the things that public health does, we have these 3 core functions. And then from these core functions, we have the 10 essential services that are encompassed within the 3 core functions. We're going to go into each one of them. But these were developed when the Institute of Medicine wrote that report where it defined what public health is. They defined the 3 core functions of public health, and this is something that I don't often say like star things, but this is something you really need to know. All of the stuff you need to know, but this is really, really important. So when we think of assessment, this is defined as that every public health agency should regularly and systematically collect, analyze, make available information on the health needs of a community. So this includes our statistics, community health needs, epidemiological and other studies on health problems. So how many of you in this room are in epi or biostats? Alright. You guys are key to the assessment one. This is core to what public health does. Okay, our next core function is policy development. Every public health agency should exercise its responsibility to serve the public's interest by promoting the use of scientific knowledge and decision-making in public health and developing public health policy. This one, I think as students, even when I was a student, I was like, I don't think I'll be doing much of this. But if we're not doing this, then other people, other groups are doing this. They're the ones who are going to be influencing policy. Okay. When the Affordable Care Act was being developed and was going through the process of being voted into law, one of the things that was not done well was promoting, so not only do we do policy development, but letting people know what we're doing. So this includes communicating that information. So the public, we're finding out now, the public doesn't actually always know what the Affordable Care Act is, what they're benefiting from it, because we haven't done a good job of explaining this major policy that has improved access to healthcare. But it's not only, so as I mentioned, it's great to assess and collect, but we need to be sharing that with those who are in power to help them make decisions that can change some of those assessments that we find. So this is policy development. And we have a lecture that I give towards the end of the semester on public health law and policy that I really like, because I think it's really, really important that we get more comfortable in public health with that policy development. And finally, the third core function is assurance. And this is to assure that the constituents, ensure that their constituents that needed services are provided by. So this is making sure that services are available, either by encouraging other entities to deliver such services, requiring them through some sort of regulation, or providing services directly. So this is a big responsibility. Public health should assure that their communities are getting the services they needed. And so we see this in the difference. Next week we'll talk more about the organization, finance, and delivery of public health, so that we'll be talking a lot about governmental public health. But governmental public health agencies often look a little bit different, one from the next, because the way that they assure may differ. So if you're in a small community, your health department in a small community where there is your one hospital is closed, you have only one clinic available in your community, you might be picking up some of that slack and providing directly some services. In a larger community, you can rely on others. There may be other people. So that'll change some of the things that that actual public health department may do and what they look like. There's this video, we're not gonna watch it, but if you want to watch a video on the 10 essential services in your free time this long weekend, you can. But so the agencies fulfill those three by delivering these essential services. So let's go to this first. So this is, you'll probably see, I think we have a poster of this on this floor maybe, just like down this hall. But this is the way that the CDC kind of illustrates these 10 essential services. So you'll see these are shorthand for the different ones, and we'll go back and look at them. But for assessment, monitoring health, and diagnosing and investigating fall under assessment. So you can kind of see where epi and biostats fall in that. Policy development, education, informing and empowering, mobilizing community partnerships, and developing policy. So those of you who are in community and behavioral health, you'll be taking more deep dives into this part. And assurance, this is where we enforce laws, so those regulations. Link or provide care. So again, it's that assurance. If it's not there, we'll provide it. If it is, we'll link you to it. Making sure our workforce is competent. That's a big one. And evaluating. And then within the middle is that last essential service, research, which is really informed and impacts all the other ones. So here are the long names of them, but I think this is more illustrative for you guys to think through. So when we think about the 10 essential services versus the core function, this is really how we operationalize or define what we mean when we say policy development, or what we mean when we mean assessment, so that you can actually have something that you can say, okay, yeah, we do this. We are meeting that essential service, and we are meeting diagnose, or, you know, we're not mobilizing as well. We need to work on this. So it's the way to actually be able to make the three core functions more tangible. Okay. So we're gonna do a activity real quick, and then we'll take a break. All right, so this activity is where we are looking to say, who are we gonna forward this message to? So pretend you are the administrator of a health department. You come into your office in the morning, you open your email with your coffee, and this is your first email you open. So this is a school principal. And a third of the students and teachers called in sick. Sounds more serious than the flu. Can someone help us find out what's going on? So after you read this, who are you going to forward this email to? You need to read it again. So principal thinks that there's something going on in their school. Who should they forward it to?
Infectious disease.
Okay, you guys are right. You can talk louder. Come on, back of the room. Okay, good. Infectious disease. Anyone else who might be involved? Maybe the clinic. Maybe health education to help them once we figure out what it is, how to keep it from spreading more. Yeah. But you're probably gonna forward this first to infectious disease. All right. Many of you had to make sure your shot records were up to date. And so this is a mom. She's afraid of meningitis. Where can she take her son to get the shot? So would we forward this to the health clinic? So the health clinic is one of those units within public health that provides services. Okay. So Ron and his family went to a restaurant last night. It was really dirty. They decided not to eat. I think someone should look into this. Who should they forward this to? Yeah, environmental health. Someone needs to come out there and inspect that restaurant, right? Okay. So they're working on their plan to deal with a bioterrorism incident. And they want to make sure their plans mesh.
It's emergency preparedness.
Yeah, that makes okay. Many seniors at our senior center have fallen in their homes. They've been seriously hurt. We think there are some tips we can share with them. Anyone at the health department who can help us put some ideas together? Injury prevention. And who else maybe? Health education, yeah. Okay. Youth director of a Baptist church. So they're wanting to see if someone can talk and do a presentation about smoking for teens. Health education. Great. Okay. So just to wrap up this section, some of the unique features of public health are that it's based on a social justice philosophy. So what I mean by that is that we believe, or public health believes, that everyone has a right to a certain level of health and a right to live in communities that keep them healthy. So that falls within the social justice philosophy. It's inherently political in nature, which we've seen play out in the last year and a half, almost 2 years, specifically around the Affordable Care Act has been the biggest one, but that's not the only part that's political in nature. It's dynamic. I find that almost every year, this year is probably the first one that there hasn't been an emerging infectious disease happening somewhere. I think it was Ebola my first year. We had Zika a couple years ago, or we have natural disasters. So there's all kinds of dynamic things that are happening. The link with government, the grounding in science. So that's why you guys are here, is to get that grounding. The focus on prevention, and that we have an uncommon culture and bond. So let's take 10 minutes to stretch and come back and maybe take 10 minutes to walk out into the cooler hallway, and we'll come back and talk about public health in and out. Yeah, I'll take it. Or do you want Then you have. My poor little phone. Yeah, I'll take it. And then.
That's the point.
Yeah.
Something like.
You look out the measles outbreak as emerging
Yeah,
because that has been a thing.
yeah, there is.
It should not be a thing, but it is.
I don't have it on me, but there's this really interactive map that shows the preventable infectious disease, like all the selected, and it'll show you a map of the US, and based on the size of the outbreak, at the largest circle around the community. It's really fascinating when you look at that, where it's happening, kind of what those communities are like that are having those outbreaks.
And it's so harmful. So maybe, I don't know if I want to I just have yeah. Cause I didn't. Did you buy it online? No, I went. Yeah, I was just thinking. It's what happens when you I'm sad, like I tried.
Also just false information. Always tends to rely on that. This is not of education and
I can see that.
Regional. Then we make the national.
That's how I ended up working with dates. Yeah, my closet is like, I should be for this. So having my closet right. Like when winter closet, their house is someone to get shit.
Right.
I've gotten everything in that watch now.
And of course,
Are
you one of my experienced students as well?
Yeah.
The heck do you live?
Closet.
Okay.
Yeah.
Okay. Alright. Yeah, I didn't know because I have you two are accelerated, right?
Yeah. It's my fun.
Not on it. Okay. I thought there was one more. I don't know. Maybe it's not you.
Hard. Also, I just feel like people can respect them. That's crazy. I talked to like, I know all my grad school, yeah, I thought it was interesting. All of my students were like, I wish I would have known. And suit pants. I didn't think of blouse. No, I get that. I was reading they thought she's not like
She is also blind. She was also blind, actually.
They watch the bodies.
So, like the midway, I she's one of my like good friends. So, I mean, I drank so I tried to give her like because like there's and I was thinking she was gonna get it. She didn't get it. Last time she changed yeah, I think
Sometimes it's hard to treat yourself and treat those or your mileage. Take the and just take some Advil. You'll be
I know, it's kind of crazy.
It doesn't matter, as long as you whatever you do, like, in the actual sewer, I can get it, I can just write with the shoe, moving on. I've already started.
That's interesting.
Like, I can
I wonder how they're gonna do my brother. I don't think they can get me hit. We have the same one.
I'm leaving the
23rd. You can always do things ahead of time. Just make sure you do your quizzes earlier. Like, so you can access those. Are you gonna have, yeah.
I already
No, he's actually not taking hours. You're rich. I was like, it's really.
Yeah, that won't be due until, yeah.
I'm going tomorrow.
They're just trying to make this.
I'm excited.
So you have plenty of time. That'll be due.
Okay.
So that's not due till after the midterm. So you're good.
But probably should we cover everything?
I'll say you again.
I don't know if we're gonna have
We
have the recorded meetings.
yeah, I record everything in Integrity. And then I upload it to YouTube so that it has closed captioning for students that need it. But it'll also be in the Integrity folder. So when you're in, you can go to Course Tools, Integrity, and you can find all the reports.
I think did you break it?
Is the midterm
The
set
one
up and then do we have to go talk to you?
got
Good
into
question,
my.
I'll answer it.
I didn't think about it till just now. So I thought about it, we were already going over the syllabus,
I don't know. I haven't.
Okay. Let's come back together. I had two kind of questions, comments that came up while we were on the break. So I I appreciate any of you who know you're gonna be gone a certain week to let us know ahead of time. If you're going to be gone, you're still responsible for the content that's covered that week. And what we do for this course is as you can see at the bottom, this is recording integrity. It's just a long recording of what we're doing in class, okay? So you can get onto in D2L. I'll show you just in case you don't know where to find it. In D2L, under course tools, there's integrity, and you can click on that, and that will be where the integrity recordings are. I also upload those to YouTube because we want things that are available to students be accessible to all. So that means you can turn on closed captioning. The only difference is it only is the screen, because integrity it's the computer screen and then this little teeny box of right here. So that's the only thing you're really losing by not doing an integrity, but you can access the course content either way. So if you're sick, or if you have plans, work related, personal, whatever, just let us know ahead of time so we know not to expect you in class, but also you're gonna be responsible for the content. Quizzes are already all up, so if you're gonna have a really busy week, and you know that you're gonna have a really busy week at week 5, you can do that quiz early. And it'll grade it automatically or what have you. So, and we only have for this class 3 homework assignments. You'll be working in teams, so you'll be working on your team projects throughout. But really, you should be able to get all that content in even if you're gone. Now, if there is some extenuating circumstance, death in a family, you're very, very ill, those things we can talk about around assignments, but we need to know as soon as possible. The other question was about the midterm. Is it the same as the quizzes? Yes and no. So with the quizzes, you can, if they're open note, open book, open whatever, and you have as much time as you need or want. I previously had them timed a couple years ago, and that was causing a lot of anxiety for students, and it wasn't really getting at what I want. Because what I want you to do, I don't care if it's when you open that quiz, that's the first time you open your book or go to the website for that week. I want you to go to the website for the week or go to the book and start reading through it. So they're unlimited time as long as you open it and you just sit there and do it. The midterm and the final are not open note, open book, and they're not unlimited time, right? The questions, though, are very similar in the style and in the content covered as the quizzes. So you can always go back to the quizzes, review your results, figure out what you may need to go back and read to make sure that you know the content. But the midterm and the final, we will be taking in 2 different buildings on campus and 2 different computer labs, so we'll get to that when we get closer to it. They're timed 60 minutes and there's like 60 questions, so that is more like what your comps will be like. So this will prepare you for that, and the questions that are on your midterm and final are very similar to that. So don't start stressing now. But just to answer your question, that's how similar they are to the quizzes and how dissimilar. Because you won't have unlimited time. Yes.
So once you open the quiz, you have to finish it and then submit it. Like if you exit out of it or whatever, then it submits it automatically. Okay.
Yeah.
Thank you.
Once a semester. Maybe twice a semester. Somebody's computer drops them off the internet or something. email us, we'll fix it for you. Now, if that's happening all the time for you, I'm gonna suggest you get a new computer or find a better reliable internet source, okay? But we have computer labs and you can get on those. The other thing that the midterm and final have is they have lockdown browser, which is not a big deal for you guys because all the computers in the computer labs have that. It essentially just locks the computer to where you just see the exam and you can't go and like Google what is public health and get the answers. And so that's more important for online students who are taking the exam in different places to make sure that their computers have that. Any other questions about that? Okay. So we've got plenty of time. Oh,
Do you choose our teams or do we choose them?
we choose your teams. And we'll that's a good question. Teams will be chosen, I'll probably do it after class next week. I hate doing it this week because students are like joining the class late or maybe deciding, oh, I don't wanna take this class, I'm dropping. So I wait until about 2 weeks in, after 2 classes, and then we'll do that. We do it with a random list generator. Not that I know any of you very well, but just so it's just randomly assigned to groups. And we'll send that out probably next Friday. Any other questions? Good questions. All right. Thought I saw a hand, but it's really just rubbing your eyes. Okay, so now we're going to talk a little bit about public health then and now. So this is a shorter section, and then we'll get to know each other a little bit more. So when we think about public health, there have been some really awesome achievements in the last century, in the 20th century. And these things have led to huge improvements in life expectancy in this country. Vaccinations, motor vehicle safety. What's included in motor vehicle safety? Seatbelts, speed limits, airbags. Yeah, so there's certain regulations on what a vehicle can look like. And then once you get in a car and you're driving on a road, there are expectations as far as speed limit, stop signs, all that. Control of infectious diseases. So we've really made huge leaps in control of infectious diseases. Now again, we always have emerging infectious diseases that will come about due to environmental factors or just the movement of people around. But we've really made leaps and bounds around this, and we'll talk about how that's impacted what are the most common killers of us now. We've also seen a decline in deaths from CHD and stroke. So we still have really high rates of CHD and strokes, but we're better at keeping people from dying, and we are seeing some improvements. A lot of that is due to public health and healthcare. Safer foods. Oh, it's easy. So we think of who regulates food? FDA. We'll talk more about that next week. But yeah, the FDA. So when you buy your cereal, there are certain expectations that you're not going to be sickened by it. We still have issues around food poisoning and illness. What was the big one last year? Or this year, I guess.
E. coli.
E. coli and what?
Lettuce.
Romaine lettuce, yeah. They just had a report that they finally pinpointed what led to the E. coli in the romaine lettuce. What was it? Yeah, animals. Like a big, in the same valley or something, there was a huge animal farm or processing plant. So they're trying to figure out, can produce agriculture and animal agriculture coexist in the same area? Because it led to not only one brand of romaine, like romaine you couldn't find it anywhere. So we have safer food, but we're finding these, when we do have outbreaks, public health is there to investigate. Healthier mommies and babies. What have we done to make healthier moms and babies? Public health. No WIC program? Yeah, women, infants and children. Yeah, so a program that helps to provide vouchers for food for pregnant women so they can get access to nutritious foods. And then that also, when the baby comes, they also have food for breastfeeding moms and their children, and also access to formula for babies as well. What else?
Education,
Education.
no smoke. Like before,
Yeah.
they used to think it was a stress reliever during pregnancy. Now,
Yeah, you watch things like Mad Men and there's like pregnant women smoking and drinking. Yeah, so we know education around helping women during that prenatal time to be healthier. And a lot of that is increasing access for women to prenatal care. So that if they're doing something that might be less than ideal, not as healthy, a physician can help point them to programs. Family planning.
Contraceptives.
Yeah, contraceptives, what major changes. So if women are able to choose and families are able to choose when they have children, then we space children out appropriately. So give moms' bodies enough time to recover. Women are having children when they're ready, so that because younger moms have often lower birth weight babies, which lead to less healthy babies. Fluoridation and drinking water. What does this do?
Stop cavities.
Yeah, this is one of those things where when we think of public health interventions, you have to do zero to benefit from this other than drink water out of that water fountain out there. Very passive. So because of that, we have less dental caries, so less cavities, and stronger teeth. And then this is recognition in the last 100 years that tobacco is a health hazard. So we now know that tobacco can lead to a lot of things, including lung disease and heart disease and strokes. Okay, so this is a graphic that we see on the left-hand side. So the blue bar is life expectancy at birth. And the green bar is infant mortality rate per 1,000. And I went and looked up this number yesterday just to see if it was a little bit higher than what we had in here previously. So what do we see happen? In the last 115 years.
Life expectancy increases and infant mortality decreases.
Yeah, so in 1900s, 110 babies per 1,000 live births would not live to its first birthday. 110. And if it did, the person would only live to, on average, under 50 years. I'd be really close to croaking soon, right? I'm glad I live in this time, right? So now, because of all of these achievements here, we have increased our life expectancy and decreased our infant mortality. So again, that's a good return on your investment, right? Public health is a good return on your investment. So the majority of the gains So when we think of this pretty much 30-year increase, 25 of those years can be attributed to public health, 5 to healthcare, such as better nutrition, sanitation, and safer housing. So we often think if we could just give people more healthcare, they'll be healthier. But really, that's only gonna make, it's gonna make a difference, but the investment in public health is gonna make a bigger difference. So, public health today, we have control, we spend a lot of time on control of chronic conditions. So one thing that happens when you live past 47 is all those things you're doing that are bad habits catch up to you, right? By 47, you might not started to see the effects of your sedentary life or your diet or your alcohol drinking or your exposure to poor air quality. But as we live longer, the impact of those long-term exposures, either environmental or behavioral, lead to chronic conditions. So we spend a lot of time in public health controlling chronic conditions. It's a focus on community-driven public health practice, which I talked about earlier, how really to have it work, we need it to be in the community and with the community. There's been a greater focus on emergency preparedness, both man-made and natural emergencies. After September 11th, there was a lot of funding that went to increasing and improving the public health and the preparedness infrastructure of this country. So we've got a lot of influx of funding to help us ensure that we have access to prophylactics in case of an outbreak, better emergency coordination systems, all kinds of things around emergency preparedness. Again, this focus on emerging infections, and Michaela, not Malika, Michaela, when we were talking about emerging things, mentioned measles. And so we're also having emerging infections of diseases that we've already controlled once. So we're seeing a rise in whooping cough and measles and other things, but really there's a lot of emerging infections that we have to be able to address quickly. And we were tested as a public health system back in 2014 when the Ebola outbreak was going on, and you can prepare all you can for different things, but really when you have something happen where we have outbreaks in certain cities, that's where you can really see where maybe there needs to be some improvement on how we do that. There's a major focus on eliminating health disparities. So when we look at that 79 years of life expectancy, and we'll look at the last thing we talked about today, we'll be looking more at health disparities. Not every person is as likely to live to 79 years. Certain people are actually going to live longer than that. Certain groups of people actually are expected to live less long. And it's not just in mortality, there's differences in morbidity, so differences in different illnesses. And so we're trying to eliminate those and make health equitable for others. We're definitely looking at the implications of healthcare reform and the ever-changing narrative around that. And then, even though we're focused on prevention, we still have to provide some direct services. What are some services when you think of the health department that the health department provides for people? Like direct services. Vaccinations.
Teeth cleaning.
Sex education. So that's a prevention service, right? So I'm thinking more direct
Oh,
clinical. That falls well into the realm of like
could you do
prevention.
STD testing?
Yes, STD testing and treatment. What else? Anything else? Family planning is another big one that public health does. So yeah, we still provide those services that are needed for our communities. Okay, so when we compare the leading causes of death, and I need to update this. Let's see. Sylvester, let's try to update this because I think there might be some additional changes since 2014. All right, so when we look at the leading causes of death in the US between 1900 and 2014, what do we see?
Infectious diseases.
Yeah, so there's pneumonia, tuberculosis, diarrhea, diphtheria. Right, so those, what is this?
Yeah,
Do I have any MDs in here? Someone Google it. Okay, so here are our causes in 1900. We do have heart disease and liver disease. We have accidents and cancer. But when we come over to
Okay, senilities, like dementia and stuff.
dementia. Okay, so we do have Alzheimer's disease, so it's just the old-fashioned name. So I can see the root of that now. So what do we see in 2014? Chronic diseases. Yeah, there's the vast majority are chronic diseases. What are a couple things on this list that were not on the previous one that are not chronic? What's on here? 8. 8's on there. What else?
Arthritis.
Suicide. And suicide. Yeah, suicide is a major problem in the US. Diabetes, suicide, nephritis. I think that is lung. Is it lung disease? Kidneys. Oh, kidneys. So what else affects your kidneys? Diabetes, right? So these are our diseases, and what we'll get into as we go into the latter part of the class, and when Dr. Corey's talking about program planning and health problems, is these are a list of health problems. You get there different ways, different risk factors that lead to these. So we'll dive into those for your group projects. Each one of your groups will pick one. But yeah, so we're seeing more, the top 3 have changed, all from infectious diseases to chronic. Because cancer, you could say, is chronic, or not, but, so these are 2 chronic, and then the 5th is chronic. So we've seen a large change. Well, I asked Sylvester if we could look at this as, since 2014, what's happened in our country? What have we seen?
Drug overdose.
The opioid epidemic. So I would expect to see, accidents, unintentional injuries is the broad category which overdoses falls into. So it might not change that much, but that's where that falls in there. And we're seeing more and more individuals die from overdoses, unintentional overdoses. Okay, so this is a little busy on here, but this is the leading causes of death by age. Because what kills us differs based on our age. So what's the largest killer of young people aged 1 to 24 years old? Did I hear accidents? Yeah, accidents. What are some of the accidents that are typically happening at that time? Trauma? Drowning, sorry. Drowning,
We have trauma, car accidents,
car accidents, yeah,
falling.
falling. What about when we get into this group, the young adult group,
Still accidents.
accidents and all other causes? Anything bigger in this group than in the younger ones? So accidents is smaller, cancer's larger,
Heart disease.
yeah, heart disease. People are dying from heart disease between 25 and 44. Less homicide, that's fascinating. Okay, so what about in the middle age group, the 45 to 64? Cancer.
All
And then heart disease is the biggest, that's not all other. So heart disease jumps quite a bit, almost doubles. And then our older adults, heart disease, yeah. Great. So you can see that the things that accidents doesn't even make the list for older adults. But it's the largest chunk for our youngest population. So when you're starting to think of a health issue that you want to address, if you wanted to address accidents, you may narrow it down into people that fall in somewhere within this age group, because accidents is like a really high cause of death in very young children. So you may create a program for that specifically. So this kind of information, again, this is that assessment data that allows us to look at and figure out what is impacting different parts of our population. Okay, so this data are showing you the 2015 and 16 age-adjusted death rates for the 10 leading causes of death. So, though we have 10 leading causes, who are the drivers of our death in this country? Yeah. So this is death per 100,000 US population. So we know that cancer and heart disease are number 1 and 2, and making changes in those can really impact life. So these health indicators indicate that diseases of aging and other chronic diseases have replaced infectious diseases and diseases of infancy. So that's like the diarrheal diseases as the major killers. But when we think about this list, there's hope, that all of us will die at some point, right? But we want people to live the longest and most healthy life, have a good well-being through their life. The silver lining is most of it's all preventable. So these premature deaths, we can make difference. And we'll talk about these health disparities because once you break it down by certain different demographics, some of the data are pretty stark that there are disparities that exist, and those are not what we think would be appropriate. Okay, so your book talks about Healthy People, and Healthy People is a 10-year initiative that sets metrics and benchmarks for objectives towards moving and improving the health of Americans. So we're getting close to the end of the Healthy People 2020 data or section, and if you go to the website, and it's one of the links in our class, you can see what the benchmark was, and then you can see how we're doing. some things we've surpassed that expectation. Some we still haven't made it. But the Healthy People 2030 will be coming out soon. So here are the main 4 overarching goals. Attain higher quality, longer lives, free of preventable disease, disability, injury, and premature death. Achieve health equity and eliminate health disparities for all age groups. Create social and physical environments that promote good health for all. And promote quality of life, healthy development, and healthy behaviors across all life stages, from cradle to grave. And so within those are actual metrics for different health behaviors and health outcomes. And these are the leading ones that are on there. So when you're in your groups and you're starting to try to decide what health outcome you want, that's a great resource to see some of the major ones that are in there, and it also gives you numbers of percentages to help you kind of think through some of that project. Okay, so what we're gonna do, have you guys been like getting to know you in all your classes? Okay. All right, you're gonna have to do it again, because I wanna get to know you. So what we're gonna do is we're gonna do a pair and share, but with a twist. So let me see if I can find it. We talked a little bit about emergency preparedness. Okay, so the CDC a couple years ago came out with this way of thinking about preparedness. So if you can survive the zombie apocalypse, you can probably survive a lot of things. So what I want you guys to do is talk to your neighbor. You might be sitting next to people you've talked to all week. Talk to your neighbor, find out their name, their concentration, where they're from, and what skill, trait, or ability they will, talent, whatever they're gonna bring. Because pretend like this class, just like on Monday when the alarm went off, but this one said the zombies are here. So we're stuck together and we're gonna fight them together. So give your neighbor what your talent, trait, or ability is, okay? To bring to our community to fight the zombies. I'll give you like 10 minutes to do this. Okay, are we getting close to exactly what we wish? Are we good? Have you guys prepared and shared? You guys have your talents and skills? Okay, I'm gonna start in the back. Because you guys, I know you guys want to be the first to talk, because that's why you sit all the way in the back, right? All right, gentlemen. Stand up so everybody can see you. So your friend's name, their concentration, where they're from, and their skill.
My friend is Dr. Awujola Abiola. He's a medical doctor from Nigeria. He's in MPH, epidemiology concentration. His talent, traits and abilities include being friendly. He's an easygoing and friendly person. He has good interpersonal relationship and skills. And he has ability to adapt easily to different situations. And he also speaks Arabic language.
So you're gonna be friendly to us, but not the zombies, right? Right? Okay,
He's Patrick Shoneke. He's also a medical doctor from Nigeria. He's studying MPH concentration epidemiology. His traits and abilities are sociable, friendly, and he has efficient problem solving skills. I think that is all.
You guys forgot the obvious one. You guys are both doctors, so you guys can help us if we get injured.
That's obvious.
Yeah. All right, thank you guys. All right, gentlemen in the back first.
Okay, so this gentleman here is Matthew Fear. He is in the epidemiology concentration. He's from New Jersey, and he served in the Army, so he has all sorts of survival skills. He can shoot, kind of defend us from all the zombies.
This is Carl Oberfeidinger. He's in the healthcare administration program. He's from Kingsport, Tennessee. He said he was a scout, so he's got outdoor survival. He's on the track team, so worst case scenario, you do well.
Leave us all behind.
I can go run for help or something.
Run for help.
Alright, so this took a while. So this Joke Moronkola, she's from Lagos, Nigeria. She's doing the environmental health concentration. Her talent is that she's a motivational speaker. As to how that would help us with the zombie apocalypse, I believe she will appeal to whatever humanity is like. She's also a pharmacologist, so she could probably synthesize some sort of anesthesia or tranquilizer.
Yeah.
So this is Henry. He's from Ghana, Kumasi, and he used to be an optometrist. So I think the skills he has to fight the zombies probably produces optical illusions that he probably might not see people in the room and just keep looking and wondering, are they humans inside there?
What's your concentration?
I'm in environmental health.
Oh, you both are together.
Yeah.
You're are two?
Yes.
Small but mighty.
Yeah.
Thank you guys. All right, did you guys do a three?
Yes, we did.
Okay.
She's a Kenya. She comes from Colorado, and she's concentration is epidemiology, and her skill is to survive with animals and to supply them some food and water.
Supply food and water.
Yeah, and medicinal herbs,
Oh, nice.
what plants you can eat, and what plants you
Good.
shouldn't eat.
What we should eat.
This is Jay. She's from China. Her concentration is biostatistics. And her skill, she's going to try to find a way to just confine them all, to keep them away from all of us. Some way to attract them to some place and confine them so they won't hurt us.
Are you gonna use math to do that?
Yes. To protect as a normal people.
This is Aaliyah. She's from Oak Ridge, and her concentration is epidemiology. And she has a very calming nature. She would make sure we're all calm and logical, so we know the next step to take.
Great. That'll come in handy at midterms. I'm gonna expect you to be very calm and logical.
Don't hold me to it.
Alright, do you guys wanna go?
Okay. This is Carrie. She's from Johnson City, and she's in the community health program. Her talent and skills that she would bring is from her undergrad. She has lots of nutrition experience, so she would provide us with food.
And this is Caroline, and she is from Reno, Nevada.
Yeah.
And there she actually undergraduate. Wait, you worked at in Sewanee.
Yeah.
Okay, and she was gonna get her health certificate or a certificate there, but chose to come here. It was a really small town compared to Reno, and Johnson City is a little small too for her. And hopes to get her certificate and social work as well as combining the public health.
Yeah, possibly. We'll see.
And what's your skill?
I have snacks in my
Okay, so this is Hannah, she's from Tennessee, in the community concentration. Her skill is that she's like really resourceful and really crafty. So, you know, when like Walmart shut down and we need something made, we can go to her.
This is Leah, she's from Knoxville, Tennessee. She's also in the community health concentration. Her skill is she was in the Peace Corps, so she can help us make a tippy tap to wash our hands. Vital skill.
Yeah, because we heard sanitation is gonna be, can't get all infectious diseases in this apocalypse. Great, thank you ladies.
Hi, so this is Kiara. She's from Spartanburg, South Carolina. She's in the community health concentration. And her skill would be that she's been in very stressful situations before and is good at getting everybody where they need to go and directing people. So I guess that would be helpful in making sure that we're not all just running around like chickens with our heads cut off and keeping us in line.
Alright, so this is Delaney Williams. She's from Nashville, Tennessee.
and she is doing the epidemiology concentration. Her skill would be, she's already done this before. She did a mock zombie, zombie apocalypse for
like
high
a-
school.
Like mass casualty preparedness thing. So.
Yeah, so she's already prepared, so she knows a little bit about everything, so she can help everybody. Sounds like so far. So, yeah.
Did you get assigned to zombies or?
I was actually working in like the hospital, so
nice.
But it was quite a event. So a bunch of high schoolers trying to figure that out. But.
Nice.
She's Denise Chavez, and her concentration is epidemiology. So she's basically using her analytical skills to figure out what is going on, and she's really proficient in MMA, mixed martial arts. So she uses her skills to save us all.
Wow. And where are you from?
Ecuador.
Ecuador. Okay.
This is Kanta. She is in the community health concentration. She's from Kathmandu, Nepal. And she would use chemical weapons to keep the zombies away from us. Yeah. Some kinds of chemical sprays we can put in the eyes and then we got into
Their
the
Alright.
Okay. This is Maboni. She's from Nigeria. She's doing epidemiology and she's a physician, so she's gonna patch us up.
Okay, I'm talking about Lynn. She's from Vietnam. She's concentrations in epidemiology, and her skill is she's worked with the National Guard before, so she has like some survival skills and all. And then I think that's all about it.
Okay, I'll talk about myself. Okay, that's fine. I'm Sarah, I'm also from Nigeria, and I'm in the epidemiology concentration. I was a PT, I was a physical therapist in Nigeria, so I can help with mobility after the injury. So, that's it.
Yeah, what is it? Missing arms.
Yeah, I can help with that.
Okay, this is Corey. He is health admin from Lenore, North Carolina, and he's really good at delegating tasks to people. He just boss us around, tell us where to go, what to do. Yeah.
And this is Lauren. Her concentration is community health. She's from Canton, North Carolina, which is close to Asheville, and she's good at having a plan of action for us all.
Oh. This is Summer. She's community health concentration, and she will keep everyone calm.
All these community health people are
No chaos. Yes. Yes, we can do breathing exercises. Yes, yoga, some Pilates, do some exercise. This is Miranda. She's from Bristol, Tennessee. She's in community health also, and she is. Are you certified in first health? Mm-hmm. Certified in first health, first aid. So she's gonna help patch everyone up and make sure that we're doing great.
Thank you, ladies.
Alright, this is Evelyn. She's from Accra, Ghana. She's in the biostatistics concentration. And she's into research, so maybe she would do research into the most populated zombie areas and tell us, no, don't go there, it's danger zone.
And this is Faye. She's from Lagos, Nigeria, and she's into HSMP. She's a pharmacist and she's into community education and creating awareness. And I believe because before the zombies come, she would have known it. So let us know what we have to do, our next step about that.
We're planning. Great. All right. Now make sure you guys pick the right three.
Okay, this is Heather. She's from Sevierville, Tennessee. And if you don't know Heather, she has like RBF, like a really like stone cold face. She's really nice, so she's gonna really intimidate the zombies. And she'll remain calm because you won't be able to read her facial expression.
Okay, this is Brian Sexton. He's from Oneida, Tennessee, and he's health admin, and his
superpower is gonna be he's very realistic and he's not gonna sugarcoat anything and he's gonna make sure we do what we need to do in a timely manner.
And this is Morgan. She is from Bristol. She is health admin and she worries a lot. So she is very observant and she will make a plan for us and get it done.
Great, thank you guys.
This is Bree. She's from Virginia. She's in biostats, and her skills are permaculture. So she's going to help us find land and teach us how to live off of it.
This is Matt. He is healthcare admin. He is going to teach us marksmanship, but he was also an instructor of Taekwondo, gymnastics, and parkour. So he's just generally going to be pretty handy for us.
Parkour?
Parkour.
Yeah. All right. Which group wants to go?
This is Naveen from Pakistan. She had a BSc, Bachelor's in Health Administration, and she's a mother of 3. Well, in response to the zombie, I believe she will help us to put plans into place on how to respond to them and maybe to evaluate the response at the end.
Or leave the kids to the zombies and they can run away. He is Thai Law. He's from Nigeria and he's concentrating in environmental health.
Oh, there's 3 of you.
Yeah. And then he has experience of public health back in the country for 8 years, and he has all sorts of computer skills. So I don't know how he has been the zombie.
Thank you.
This is Amanda. She's in HSMP. She's doing the accelerator program. From Bristol, right?
Yeah, you can say it close enough. Bristol works.
Oh, I just forgot all of those people. I just forgot. Her skill is helping to keep people calm. So she's gonna join the calm crew and make sure we're all in it to win it at the end.
And this is Michaela.
I'm introducing Seth, sorry. So this is Seth. His concentration is health administration. He's not sure what he wants to do exactly with that, probably something federal, still trying to figure that out. And his skill is going to be, was it preparedness and cure?
Yeah,
Delegating? Okay, there we go.
I also suggested allocation of resources.
Yeah, allocation.
There we go.
Okay, everyone, this is Michaela. She is from, I've already forgotten, so. Raleigh. And concentration is epidemiology, and her skill in a zombie apocalypse would be just keeping everybody lively, humor, so making sure that we can all laugh about getting bitten by a zombie, something like that.
Comic relief, y'all.
It's important. Very important.
Great. All right, Sylvester, what's your talent?
Yeah, I told you I can see to the future. I can decide. I know when they're coming.
Know when they're coming.
Yeah.
All right.
What's your turn?
Let's see. I have a really good stern voice I've learned in the last 2 years, so I can like no, do not come into our village. And then I also like to garden. So if we are out of this room and we have some land, I can help with that too. All right. Now you guys are never gonna forget whose skills are what now. So at least I won't. This helps me out. Okay, so the last kind of half of the class, or the last little bit of class, so we're more than halfway done. We're going to talk about determinants of health and then health disparities. So there are lots of different determinants of health. We have our social and economic, and we're going to go into these in more detail. The physical environment, biological factors, our personal behavior and our lifestyle, and then our access and use of healthcare services. And it's the interaction of these factors together that determine our individual health and that in aggregate the population's health. So this is like an old graphic, but I can't ever find a newer one, and I'm too lazy to make one. So this is kind of how we can look at the biological, the environmental, or the biology, the environmental, and the social aspects, and how they kind of break down, and how they all impact public health and health. So first we're going to talk about the social environment. Which includes poverty, education, and then the cultural environment. So how does poverty affect our health?
If you don't have the money to get the food, then you starve.
Yeah, so we talked a little bit about it when we talked about jobs. If you don't have money, you can't buy food. What else?
Low income areas are usually in food deserts, so they don't even have access to medical foods they need.
Yes.
Generally poor water quality as well.
Poor water quality, poor housing, poor access, like access to food is very different because they may not have access to food beyond either fast food restaurants or bodegas or gas stations. What about education? What's your education?
Nutritional health.
Nutritional health, so like it can impact, so even like your education about health can impact your ability to do something about it. Yeah. What else about education?
The more education you have, the better likely you are to find a job that pays well, so it plays into poverty.
Yeah. So when you think of these social determinants of health, they're very interrelated. And it's like a chicken or the egg kind of thing. Education can lead to higher educational attainment, can lead to more opportunities economically, which decreases your likelihood of poverty. But also impoverished areas, how is education in impoverished areas? As good, better, worse? It's typically worse. How do we fund schools? Property taxes. So areas with more property taxes, which means more people with incomes to buy houses, have better schools because their schools have more money. Areas with lower property values, more rental properties, less finances for families, have less money going into the schools. So the education and poverty are very interrelated. Poverty or income is the what we call the primary social determinant of health. It impacts all these other ones. Because we have what is called intergenerational poverty. It's very hard for individuals and families to break out of poverty. It's not impossible, but there's lots of barriers to it. So if you can break out of poverty, then it opens up a lot that interacts with your health. Okay, another determinant of health is the physical environment. So not just the social environment, but it's issues that relate to environmental health. So where I used to live in St. Louis, we had some of the highest blood lead levels in children in the country. Where do you think kids were getting lead from in their blood?
Paint.
Paint. What kind of paint?
Lead paint.
Yeah, old lead paint. So St. Louis is an old city, and there's some parts of town, like I own a building was built in 1910. But since 1910, it's been painted multiple times, and we have new paint. There's some parts of town where the paint's chipping, these poorer housing, and for whatever reason, children, my child included, like to chew on like the window seal and things, like weird things kids do. But they get, if it's in the air, they can breathe in the paint. If it's on the ground, they'll put it in their mouth. Why is lead a problem in your blood? What does it do?
Can lead to aggression.
Aggression? What?
Low IQ.
Low IQ. Yeah, so which can relate to aggression. It affects the neurodevelopment of children. So if we get exposed to, at this point in our life, lead, and we have higher lead levels, it's bad, but in children it's very bad because it can stunt their neurological growth. So there's lots in St. Louis around lead abatement, like painting over, doing, chipping it off in certain ways. So that's just one example, but there's tons of things. Very recently, in the past, gone on too long, there's been news about safe drinking water in what community? Flint, Michigan, and Detroit area, right? So there's poor piping in the communities. It hasn't been maintained, the water source isn't good, and they're got bad water that's making people sick. Wastewater treatment, we all have access to this, who live in cities, and then some people live on, septic. But all of these different things, the foodborne illnesses we talked about a little bit, all these physical environment exposures impact our health. And there are communities that have higher rates of physical environmental issues. You might have a community that has poor ambient air and lead issues and issues with indoor air quality. And so it's not just one. All of these can, again, interact together to impact our health. Okay, biological, that's pretty simple when you think about it, but it's our genetics. Our genetics don't always, there are some diseases that if you carry the gene, you will get it. But most of the time, you have your genes, and those plus your behaviors really determine your susceptibility of disease. And what is that called? It's a part of genetics. Inheritance? No. Epigenetics. So like the study of how your genes and the external world work together. It's called epigenetics. Because it's hard to change genes, right? Like you're not going to be able to change my genes at this point. But I can change things about how I interact in the world, so my behaviors. We can hopefully make changes to improve the air quality and lessen exposures that may increase likelihood of something I'm predisposed to. And then we have our lifestyle. So we are not just passive in this world, like things are happening to us, right? We do things our personal behaviors do have an impact on our health. So when we think about what are some behaviors that can decrease your likelihood of good health? Smoking. Sedentary lifestyle, that is something that we all probably, I mean, you're sitting in a classroom for 3 hours. I'm impacting your sedentary lifestyle right here. I apologize. What else?
Exercise. Exercise.
Exercise, yeah, so the inverse. So getting up and moving our bodies and exercising.
Drug abuse in general.
Drug abuse. Diet.
Poor hygiene practices.
Poor hygiene practices.
Stress management.
Stress management. Alcohol. Yeah. Well, just risky behaviors in general, right? Driving too fast. Not wearing your helmet when you ride your bike. All these things that we do can impact our health. The things that are really impacting our health is around those major killers are what? What's leading to increased heart disease and
Sedentary lifestyles.
sedentary lifestyles, smoking,
Nutrition.
and what we eat, yeah. Those are hard things to change though, right? That's why the community health students are gonna learn how to create programs that make us change our behaviors. Okay, so we're gonna do an activity. There's 3 sheets of this. We'll turn to the first one and talk, and you can work with your classmates. But what you're gonna try to see is, the other one is healthcare, so access to healthcare. There's a list of risk factors, and you're gonna tell me if it's a social, physical, biologic, behavioral, or healthcare. Okay? So go ahead. You can work with your classmates or work with them.
Yeah. Thank you.
Okay, so what about number 1, poverty? Okay. Number 2, low education level. 3, air pollution. Occupation. Social. And physical. What do you think? Could it be physical as well? Think of where you're at. What if you work at a power plant? Behavioral? I'll take it. Alright, what about number 5? Water pollution. Physical. Sedentary lifestyle? HIV exposure. Biologic. So the physicians, biologic.
There are different perspectives looking at
Yeah, so do some people have more susceptibility to?
Yes, some people could be more susceptible.
It depends on how your sexual behavior. All right, lead paint. Poor eating habits. And then the last one, global warming. Okay. All right, you guys are getting just warmed up. Now here's the next set.
If we had that
Okay, so number 11, lack of access to vaccines. Number 12, smoking. What about secondhand smoking?
That's social.
Social?
Sorry to back up. I'm thinking 11 could also be social in case of maybe poverty or something like that.
Yeah, so your access to vaccines could be impacted on the social, so the poverty of the community. Great. And smoking is behavioral, but if it's secondhand, physical, social. All right, substance abuse. Behavioral. What about ultraviolet radiation?
Or behavioral if you're tanning.
For tanning? Don't tan. Don't do it. Yeah, so it could be, you could be increasing, if your behavior, such as tanning behavior, either outside or in a tanning bed, that increases your exposure, but that's your behavior. But also there are certain parts of the world that have higher rates of ultraviolet radiation. Genetic susceptibilities.
Biologic.
Biologic. Number 6, maldistribution of healthcare, 16, maldistribution of healthcare providers. Healthcare. And aging. Okay, one last page of these. Now that we're getting physical. He's like him.
She was reading. I don't know what I was gonna say.
What is fatalism? You know what that is? So it's a way of seeing the world that no matter what you do, you can't change.
Oh, yes.
Change what's gonna happen. I'm sick, I'll always be sick. There's nothing I can do to change it. Okay, what about bioterrorism? Physical. Hurricane Katrina. And social.
Just like situationally, a lot of people where they were.
Yeah. Yeah, we saw, I mean, even when we see the difference in Hurricane Harvey between Houston and Puerto Rico, I mean, they were impacted differently, one's an island and other, but the social piece and the infrastructure really impacted. I mean, we just heard that almost 3,000 people died in Puerto Rico from Hurricane Harvey. So yes, physical, but then that specific example, Katrina, had a lot to do with social, and I think all of when we get into talking about emergency preparedness, we'll talk about that, because really it's who's the first on the scene? Is it the federal government? No, it's the people in the community. So if the community doesn't have the resources, that first impact's gonna be different. Okay, flooding, contaminated meat products, healthcare. What do you guys think? Yeah, so the environment. So if we think about, that's most likely physical, unless you're making your own food or you have your own food. No primary care. What about race and ethnicity? Is it biological? How is race and ethnicity biological?
Race is a social construct, so
when we think about race and ethnicity, if you look across the world, the races and ethnicities we have in the US may not translate to the races and ethnicities that are in another country and what they define. So we typically see those as social because they are social constructs that are set up by different societies. But based on those social constructs, they do have a lot of impact on our health. Different communities or different people who are put into certain races and ethnicities may not have access to the same things as others. And that's where we see the health disparities, but yes, it's social. All right, tsunamis, cultural beliefs, social. How do your cultural beliefs impact your health?
Some cultures don't believe in vaccines.
Some cultures don't believe in vaccines, yeah.
Or healthcare and all.
And what?
Blood transfusions.
Blood transfusions, there's some populations that don't, cultures that are against blood transfusions.
Some cultures do female genital mutilations, which impacts on the.
Yes, so there's some, yeah, an example is, female genital mutilation, so that impacts your health. Some cultures you may have cultural beliefs about even food, like what we eat. Your culture may have foods that are not as healthy, but those are your cultural foods. You're gonna eat them. I'm gonna eat my cultural foods, even if they're not as healthy as the salad. What about fatalism? So I hear behavioral, I hear social, are those the two? So, why behavioral over social, or is it both? Could it be both? Because having a fatalistic worldview impacts your behaviors, right? Because if you believe that, no matter what I do, I'm gonna be sick, you're probably not gonna do much to try to change the way you feel. But it's typically, it happens with not only individuals, so we can think of individuals in our families and things, but it's a social piece too, because communities can fester in communities where they feel like it doesn't matter what we're trying to do, we can never improve. So why try? Okay, you guys did a good job on that. Even the ones that I put in there that were just supposed to trick you, you guys didn't get tricked. All right, so when we think of those determinants of health, this is just a busy graphic showing just the interrelatedness. As we've talked before, none of these affect us in a vacuum. They're impacted and they impact the other ones. And all of this is impacted by the superstructure of policies and interventions, as well as healthcare. And all that together in this complex web leads to our health, individually and in a population. So, which policies affect health? Yeah, this is a trick. All of these affect health. Social and economic, occupational, educational, environmental, research, healthcare, and regulatory. All of these types of policies affect health. And so when we think about public health, remember 3 core functions of public health. One of those is policy development. Okay, so they all interact, and that social position affects the other influences. So poverty is associated with adverse health event outcomes, and race is independent of your social economic status, is linked to mortality. So we're going to look at that in just a second. And public health promotes those programs and things that influence all health. Okay, so this is the health impact pyramid. This is another thing that it's like, we'll come back to this because it's hard to wrap your brain around it the first time you look at it. But what we have is the health impact pyramid. The bottom are the socioeconomic factors. The next level up are changing the context to make individuals' default decision healthy. So changing the context to make it easier to do the healthy decision. Long-lasting protective interventions, followed by clinical interventions and counseling and education. So what this is showing is that at the bottom, if we make impacts to the social economic factors, if we change the social, if we improve schools, if we increase access to good paying jobs, if we help to improve issues around poverty, that has the biggest population impact. Because we know that these social contexts can lead to multiple different issues with our health. Going up, they have a smaller population level impact. Not saying that these don't impact the individual, but at a population level, when you think of counseling education, it's really important to change individual behaviors. But if we, outlawed French fries, less people would eat French fries than if we just tell them they're unhealthy. No one's gonna outlaw French fries. You'll have a riot on your hand. I'll be in there. But we do this when we decrease, when we have a smoke-free campus, right? That makes not smoking the default on campus. So as you go down the pyramid, you increase the impact. And it makes less effort on the individual. When you go up, there's more individual effort needed to change behaviors and impact health. What are long-lasting protective interventions? What would fall into that? Vaccinations? Yeah, things like that. That you don't have to do to change your behavior. It's only one or two things that people have to do versus, if I'm gonna have to eat right, I'm gonna have to eat right 3 times a day, 2 snacks a day, whatever it is. No cookies at night. That's more effort versus, vaccinations and things like that, where it's one behavior that you're changing. Does this make sense? The problem is these two at the bottom, the reason we don't have a super duper healthy, population in the US and worldwide is these are really tough to do, right? They take a lot of effort, not on the individual, but societal. And that's why we do see a lot of stuff happening up here, because we need to improve health of the population. It would be great if we could do more down here, but again, it's really tough. Because those things, people feel very strong feelings about individual liberties and things around that, welfare and social contracts and things like that at the bottom. So, okay, in the last 10 minutes, which I hate that we're rushing into this last part because it's really important, is on health disparities. So here is a graphic. So remember at the beginning we said life expectancy on average in 2016, I think it was 79 years. Here we break it down by gender and race. And so in the US, you typically have white and black as the main 2 races that you see, and then others are at a smaller percentage in the US. So this graphic just has it broken out by white and black and male and female. So what do we see? What's the first thing we see? Who as a gender lives longer? Females. Why do women live longer than men? Because did I hear men are dumb? So yeah, it's kind of has a little bit to do with that. We lose more young men due to accidents, unintentional injuries, because for some reason young men are more risky in different aspects, cars and things like that. So they're not dumb, we'll just say their brains haven't developed enough that they're not gonna risk. But that's a lot of it. We have more men dying at younger ages, which pushes down that life expectancy, because that's an average, right? So if you have more men dying, say in their late teens and then into early adulthood, that's lowering that life expectancy. So women live longer than men, and that's true for both white women and black women, right? They live longer when we look at this end. Well, here's the good news, right? We see an increase in everybody over time. Everybody's living longer. But what else do we see? Yeah. When you look at white women versus black women, white women live longer than black women. When you look at white men versus black men, white men live longer than black men. Black men have a way lower life expectancy than everyone. I mean, the magnitude is incredible when you think about that. The years of potential life lost in black males. And if you were to take this, you'd have to go, let's see, let me go to back to almost the 80s. Somewhere in the 80s, where white men were living had the same life expectancy as black men today. And this is why, we believe in public health, and I think we should as a country and as a world, that this is not okay. There shouldn't be this type of disparity in life expectancy. So women live longer than men, and then there are disparities in that life expectancy based on race. And we could look at a lot of different data on not just mortality, but morbidity. This is interesting. Should where you live impact your life expectancy or death rates? Should living in Tennessee make my life expectancy different than living in, say, Washington or North Carolina, just across the border in North Carolina? It shouldn't, should it? Should where you live?
No. Well, it kind of depends on if you're near a water source or not, also.
Near a water source?
So that you can't live.
So where has the highest death rate? So these are death rates. So the larger number equals bad, worse. So where are the highest age-adjusted death rates in the United States? The southeast, yeah, right here. Except for Florida. Florida's doing something different. Florida has all these people from up here that moved down
Doesn't
here, right?
count like panhandle area, which they consider really.
Yeah, like this area.
Yeah.
Acts more like it. Yeah, so we see that we have poor health, including in our great state of Tennessee. So even though it shouldn't, it does impact our health. Why do you think this is? Why do the people in the southeast region of the United States have poor health or have higher death rates?
They have more rural areas.
Tobacco farming? Yeah, so tobacco is very ingrained in a lot of communities. So there's the agriculture piece, the social piece, but it's also the behavioral. There's more smoking in this region. our part of Tennessee has some of the highest rates of smoking. We have really high rates of smoking in pregnant women as well. Really high. So what can we like think about this, not as just this, but what else goes on in the South?
We're overall poorer than a lot of other regions.
We're poorer. We're a poorer region. We have a lot of people in our region too. It's a population dense region compared to out west, in this area. Very dense population in this area. Poor. If you're generally poorer, like we said, that's the strongest determinant of health, social determinant of health. Any other thoughts or reflections on this map?
There's less social support and also like more religious stigma against certain things.
Yeah, we are in what we call the Bible Belt, right? We're in a very religious area, so that can impede certain types of discussions, possibly access based on religious beliefs. That's that cultural piece. And what was the other thing you said?
Just like social support, there's more of a focus on like markets and not.
Mm-hmm. Yeah, so maybe some things about the way we interact with each other. Okay. You guys are being nice. There's a lot of other things that happen in the South.
Guns.
Racism, right?
Guns.
Guns. Do we have a lot of guns in the South?
Yeah.
Yeah. We like our guns. But just having a gun in the house increases all kinds of likelihood of death. Predominantly suicide. So if you have a gun in the house, it increases your likelihood of using it to commit suicide. So, kind of in closing for the day, right on time. Social and economic factors influence the life process and are powerful determinants on our health. As we know that if you're poorer, as we've talked today, you live a shorter life, and that life that you live is less healthy. So not only is it shorter, but it's your health and well-being is less. And it's life expectancy appears to be more related to income inequalities than the average income or wealth. So that's really interesting. So in communities where everybody is poor, the impact of income is not as big on life expectancy. But when there's major gaps between the haves and the have-nots, that's where we see a lot more impact. So like I said about lead, there's different things that impact children and can be devastating for children who live in less economically resourced areas and aren't in affluent families. Okay, and so we need socioeconomic policies. It's a big part, like we said, from the health impact pyramid. All right, that's it for this week. Don't forget to do your quizzes before next week. They're due on Wednesday, and we'll see you then.